We're streaming live from wonderful Cheyenne, Wyoming. Thank you to everyone who is attending in person. Thank you to everyone who is online. We're here today to talk about MS with Dr. Rob Gross. I'm Kelsey Morrow, Education Manager for the Rocky Mountain MS Center. I would also like to thank the pharmaceutical companies who have provided patient education grants to support this series. Thank you to Biogen, Genentech, and Novartis. This speaker series is just one piece of our education programming. We have a variety of formats available to you, including both in-person and online options, with most of our programs also available on demand on our YouTube channel. Our most recent edition was our Spring Education Summit, where we covered topics like research updates, brain volume changes, evaluating risk and benefit with medications, and MS progression. The next event in this Q&A series will feature Dr. Andrew Wolf, and that will be on July 11th in Grand Junction and online as well. We do announce all of our educational opportunities through our mailing list, our Facebook page, and you can sign up for notifications on Eventbrite. And all of our education programs are free of charge to anyone interested. And now I'll introduce you to Dr. Gross. Dr. Gross attended college at Columbia University and medical school at NYU School of Medicine. He completed an internship in internal medicine and residency in adult neurology at Brown University in Providence. He then returned to New York to complete a fellowship in MS neuroimmunology at the CGD Center for MS at Mount Sinai Hospital. Dr. Gross sees patients with MS and related disorders of the central nervous system. He divides his time between patient care, teaching, and clinical research. We did have a lot of great questions submitted at registration today, so we will get to as many of them as we can. Just recognize that all of the answers are provided for informational purposes only, and all decisions regarding MS treatment should be discussed with your neurologist. With that, I'll turn it over to you, Dr. Gross.
Great. Thank you, Kelsey, for the kind introduction. This is Conversations on MS, so it's very nice if it can be somewhat conversational. I know I'll probably be doing the bulk of the talking, but if anybody wants to chime in at some point, raise your hand. If I'm speaking too quickly, sometimes I can do that when I get really excited about something. So, just tell me to slow down, or if you didn't understand something, I can repeat it. That's all fine. Yeah, I do have a list of questions here that people submitted ahead of time, but maybe I'll open the floor right now to anybody who has a question. We can just kind of dive right in. Don't be shy. The young lady in the front.
I used to be shy, but I outgrew it. There's a site that I go to, and it's free to anyone who wants to just go online and give them your name. They send it out twice a week on Tuesdays and Thursdays. It's called Healthline, and you just put MS on there, and you get a newsletter every Tuesday and every Thursday, and it's informational. But since it is Thursday, I got one today and did come in with a bunch of questions, but I already sent mine in except for this one. It's a study that's going on right now. If I can find it, I'll just ask about it. It's a combination of metformin and
clemastine.
Thank you.
The one in the UK.
And the intent was that it could possibly restore the myelin sheath, not restore, maybe repair or restore. Do you have any information about that?
Thank you for your question. I was just pulling up, I wasn't trying to be rude, I was just pulling up Healthline as you were talking. Looks like a very nice website, but I haven't actually looked into it deeply yet. As far as your question, yes, both compounds, clemastine and metformin, are being studied in a clinical trial to try to see if it can help repair or remyelinate. The trial, as far as I know, it takes place in the UK, Cambridge, I believe. There's been some interesting kind of preclinical work, not in humans, but before we get to humans, kind of thing that suggests potential benefits with either of those two. The clemastine story is actually quite interesting because the way it worked initially, there were some researchers in San Francisco who screened a huge library of already known about compounds or medicines, and they used this platform where they had like these tiny little wells or micropillars, and they had like an oligodendrocyte precursor cell, or an OPC, the type of cell in the nervous system that eventually becomes the grown-up oligodendrocyte and produces myelin. And they had like one of these cells in each little thing, and then they added all these different compounds. And as kind of this high throughput screen, they determined that, of the thousands or whatever that they looked at, a handful of them showed a lot of promise in the test tube of kind of promoting myelination. And one of those was clemastine. And so it's since that time been in trials in humans, in people with MS, to try to see, will it actually help, because it's one thing to do it in, the test tube or in a mouse model of MS. It's a whole nother thing to actually show benefit in a human being. Not only benefit, but that it's safe and well tolerated. So that's the purpose of clinical trials, right? We have to test these things out. And so, sometimes that can be, it can seem slow and it'd be frustrating because you're like, why can't we just, now on the one hand, these medicines are available. I mean, metformin and clemastine, they're both, they're in use. They have been in use actually for decades to treat different things. Clemastine is kind of an older antihistamine, so kind of like a Benadryl. And metformin is used to treat diabetes and other metabolic disorders. So they are available. And the question is just like, is it actually useful? And and in whom might it be most beneficial? So I don't think we actually have the answers for those yet, but hopefully this study would help further that knowledge along. Other questions? Yes.
This kind of might be more specific, but my sister tends to send me a lot of, for lack of a better word, conspiracy theory websites. And but anyway, both my sister and I, we were exposed to arsenic poisoning when we were younger. And this one site claims that arsenic poisoning can trigger autoimmune diseases such as MS, Hashimoto's. My sister has Hashimoto's, I have MS. And I was just wondering if there's any kind of validity to that, or if it's just another junk website.
Well, I don't know if the website is junk or not. I have not heard of that particular link with arsenic. I mean, I think we're still learning. We know a lot more now about what causes MS than we used to. Certainly, people can have a genetic predisposition. So we see higher rates of MS in family members of people who have MS or other autoimmune conditions too. So you said Hashimoto, right? Right. So that's not uncommon to see that kind of clustering of autoimmunity in a family. What we know about in terms of, besides the genetics, which, we could talk more about too, is that there are other kind of what we call non-genetic or environmental risk factors for developing MS. So certain things like cigarette smoke increases a person's risk for developing MS. Having low levels of vitamin D increases the risk for MS. Now, some of these things, I mean, there are a lot of people who smoke who don't get MS, and many of us have low levels of vitamin D and we don't get MS, but it's called a risk factor because in somebody who is somehow predisposed, maybe genetically, you get exposed to enough of these risk factors, then you through sheer lack of luck, you end up with MS. So that's kind of how we think the sequence of events happens. And it's not incredibly uncommon, right? The MS, compared to some of the other things that exist in the world. MS happens in like 1 in 300 or 400 people. You know, so it's higher in first degree relatives, again, maybe like 2 to 3 or to 4%. But so not super uncommon as a disease.
My sister-in-law keeps sending me information.
I'm seeing a theme here.
I'm sure everybody gets it too, but it's on gut microbes and how, if they're, I don't know what they would be, but if they're not in balance or whatever,
Alright.
it can impact my exacerbations and
Yeah.
my symptoms. No?
Was that a question? Yeah.
Yeah.
Candidate? Probably. I think we're just really at the infancy of kind of understanding what's going on in our guts. You know, if you think about it, we're actually there are more bacterial cells in your body than there are human cells, like by a lot. Many of them reside in your gut. And so they're probably doing something. There's been increasing interest in this area in the past few years in MS and in other conditions, but some studies have shown that certain species of bacteria or certain genuses or geni of bacteria are like more represented in the guts of people with MS than people who don't have MS. I think, you know, how do we use that to our advantage is a really good question. How can we manipulate our gut flora to, you know, provide some protection? Hopefully, I think is one thing that I would like to see more research looking into. You know, a lot of people ask me about like probiotics or antibiotics, I guess, for that matter. They may very well have an impact, not just on the health, but potentially also like on the way our body processes like medications, you know, potentially like how much they get absorbed. You know, there could be a lot of things that could be interacting with through the gut. You know, it's the way our body kind of perceives the world in many ways. Yeah. Yes, in the back. High white blood cell count? Not as far as I'm aware, no. White blood cells are, you know, your immune cells, you know, so you have red blood cells, you have white blood cells, you have platelets and other things kind of floating around in your blood. Most of the time when I diagnose and when I treat people with MS, we look at their blood counts. The general counts are normal. You know, we don't tend to see elevations or reduction. Sometimes we can see reductions in certain classes of white blood cells, particularly when we're treating people and we're eliminating those. So then they would be low, but usually overall count is normal. Yeah. These are good.
So you were talking about the genetic disposition.
Yes.
It used to be like 25 years ago when my mom was diagnosed, they didn't say it was more
Yeah.
environmental,
Yeah.
regional or
Yeah.
whatever. So is there a way now like that kids can be screened, or should we look for vitamin D deficiency or?
This is a great question. For the most part, neurologists are not screening people like children of people with MS for MS as part of kind of just general health maintenance. That's not a thing that typically happens. We do have a study or a pair of studies that we're doing at the university to look at, you know, what could be kind of some early manifestations or changes that we can see in the blood of people, or, you know, on the MRI of people who have first degree relatives with MS, but who they themselves are not, don't have any symptoms.
That's fine, like I can treat for.
Yeah, right. Right. And so, yeah, so we're starting to see some interesting results that, you know, they're even, you know, I said like 2 to 4% kind of thing, but even probably up to 10% of people with like a parent with MS, for instance, might have some kind of abnormality that is detectable. And the better our tests get, the more we might see. Now that might never turn into anything, you know. But it's something that we're starting to see. So we're, the idea is how early can we detect something? Because presumably, the earlier you intervene on something, the better. But then, of course, the question gets raised like, well, again, what if nothing ever happens to this person? Why is it worth it? But then you bring up something like vitamin D, which is, I think it's pretty low risk to check or supplement, with vitamin D, if you're, a kid with a parent with MS. It's usually probably a good idea. Kids and adolescents with obesity are at higher risk for developing MS. And so trying to avoid that as best as possible. I mentioned cigarettes, tobacco is just really bad all around. And so you should make sure your kids never smoke. Probably. Yeah, yeah.
The question was, does that include?
Oh, sorry, yes, thank you. The question was, does that include secondhand smoke? Yes, over here.
Is there any quantifiable link between the number of oligoclonal bands and the disease prognosis?
Great question. I'm gonna say generally speaking, no. I did see a small study years ago that looked at that and that found that higher numbers equated to worse outcomes. But I think by and large, there's not a great link for that. Yeah, so the oligoclonal bands that's one of the tests that we look at for diagnosing MS. It's essentially production of antibodies in the spinal fluid. You're supposed to have antibodies in your blood. That's how you're immune to lots of things. But if you're producing it in your spinal fluid, that's usually not a good sign. It indicates there's some kind of abnormal immune response going on there. So in the right context, that's consistent with MS. And usually we say 2 or more of these bands in the spinal fluid is consistent with that diagnosis. Now, previously, or in some places still, you might hear like 3 or more or something like that. But like once you get like kind of beyond 3, it's really more of a binary thing. You either have it or you don't have it. And interestingly, with our medications, at least all of our current medications, you could be doing very well clinically. But if for some reason you were to get another spinal tap, you'd still have the bands. So it's not actually a marker for how the condition is doing. Yes.
I should have warned you that I was gonna be.
Oh, this is great.
Because I can come up with questions. that
I love it.
leave me.
I love it. That's why you're here. Yeah.
I have 2 questions regarding Ocrevus as a treatment for MS.
Okay.
My first question was that I was told probably within the last 3 months that Ocrevus was used as a treatment for the younger people until they reached the age of 55, and that they found now that Ocrevus beyond the age of 55 is pretty much of no use.
Who told you that?
It was a study that I was told about by my neurologist. Of course, she looked at me and she knew that I'm probably the most stubborn person in the world. And I don't have the type of MS that I have primary progressive. And I looked at her and I thought, I believe Ocrevus is helping me. And so she knows that I wasn't going to give it up anyway. So, but I was curious as to whether you knew anything about that. But the other question that I would have is that, again, I've been reading that now Ocrevus can be delivered in less than the infusion, but now they have an injection that takes about 10 minutes as compared to the 4 to 6 hour infusion. Are you aware of that? And if you are, is that available now in our part of the world?
Great questions. You're not with Roche Genentech, are you? Never mind. So the first question, so yes, is there kind of an age limit for Ocrevus or for MS disease modifying therapies in general? Actually, a topic near and dear to my heart. The short answer is there's no set cutoff for me anyway, that I would say, oh, you reached that age, we're done, kind of thing. What we do know about MS, though, is that it changes just kind of naturally over the course of a person's life with it. And what we know about our treatments, the ones that we currently have, not just Ocrevus, but pretty much all of them, are that they tend to work best earlier in the course of the disease. They tend to work better in relapsing forms of MS than in progressive forms. They tend to work better in people who are kind of chronologically younger than older, and in people who've had kind of more recent disease activity rather than no recent disease activity. So those things kind of tend to they tend to help us in terms of when we're trying to figure out, is this person likely benefiting from treatment? But it can be tough to know because, we talked about the oligoclonal bands not being a good marker for like monitoring. We don't actually have good markers for monitoring MS I mean, we have MRIs, and MRIs are great in some respects. They've certainly come a long way. We can see a lot more stuff than we used to be able to see, but there's a lot that an MRI can't tell us. And especially, I see people who are getting worse and their MRIs are not changing. And they say, well, how is that possible? Why am I getting worse? My MRI is not changing, right? And so the truth is that we need better markers of the disease, when the disease is doing worse and when the disease is doing better, and so both, that would, help with this kind of, situation of figuring out like, okay, well, if we're going to like stop a treatment, how's it going to go? Or something that could be predictive also would be nice to have, if, say, this is your readout on this test. It says that you have a 99% chance of doing well off treatment or doing the same as you currently are doing off treatment, off treatment as on. So then that would be very useful information to have. And you say, well, in that case, well, why bother with this really expensive, treatment, And so we're always trying to navigate this, kind of balancing the risks and benefits of treatment in general. And, we kind of have to use the information at our disposal, and there can be uncertainty for sure. It's not like we had two identical versions of you. One we can keep on the drug, one we can take off the drug, right? And then we can kind of do this scientific experiment and see like, oh yeah, a drug seems to be working because, version A of you, what's your name now?
I think I was told about that because they said that Ocrevus has a tendency to damage or weaken the immune system.
Yes.
And of course, MS weakens the immune system as well, but I think that's why I was told that maybe they were looking at the benefits versus the risk of immune problems.
What is your name, ma'am? Your name?
Oh, I said, I think.
What's your name?
Oh, my name is Helen.
Helen. Nice to meet you, Helen. You're absolutely right. So we're trying to, again, assess risks and benefits of this. And because all our medicines really can have an impact on the immune system, the main kind of side effect or complication that we're worried about is, are we increasing a person's susceptibility to infection, right? And that can be more of a problem as people get older and the immune system kind of weakens naturally, a process called immunosenescence. So, where was I going with that? Lost my train of thought. So okay, so then we have, the way we figure this stuff out a lot of times is by doing studies. And when we do studies, we're kind of comparing groups of people and we're looking for trends, right? It doesn't necessarily tell me, what's going to happen in your case, but it can tell me what's happening in, people who are kind of similarly situated, depending on the study. And so there've been a lot of studies that have looked at what happens to people who go off disease-modifying therapies, and sometimes things get worse and sometimes they don't. And one of the big trends that has been seen is that, older people, when they stop their disease-modifying therapies, tend to have fewer exacerbations, MRI changes, et cetera, especially like kind of beyond age 60. And younger people may be at higher risk, especially below age 45. And then in between, there's kind of a gray zone. And that's more like looking at disease activity, defined as like relapses and MRI changes. In terms of progression, that's a little bit trickier, and we've always done kind of a worse job at kind of quantifying that. And as the treatments generally don't work as well on that side of things anyway, it can be kind of very difficult to ascertain whether something like Ocrevus is working versus something. So long-winded answer to your question. So that was question one. Question two was, oh dear. So yes, there is a subcutaneous version of Ocrevus. It's called Ocrevus de novo, or maybe it's just de novo. Anybody? Yes. Okay. It is newly available. As you said, it is a subcutaneous version of ocrelizumab, an anti-B cell therapy.
They said it was still only twice a year.
Correct.
6 months.
Correct. You would still, I don't think people are getting it at home. I think they're still having to go to like an infusion center to do it. And so they administer like a small amount of fluid into the abdomen or wherever for a subcutaneous tissue. And then it does this thing. And yes, it's supposed to be a faster process than the IV. The IV, we've, in many cases, it has sped up if somebody's been on it for a while. So we're not necessarily keeping them for hours and hours and hours. But yes, this would be an even faster, more convenient.
Dr. Gross, we did have a couple questions online. We had a woman say, "Thank you for coming to Wyoming."
My pleasure.
She's always trying to blame her aches and pains on MS, but recently found out she's got arthritis. Steroids have worked a little. She's thinking about surgery. Is there any connection between the arthritis and her MS?
Well, there's a connection insofar as they can both make you feel great. I mean, generally, you try to see what are the contributing factors for any particular symptom, and that's what we have doctors and health professionals for, and tests and so forth. And so, if it's determined that a person has MS and something else, then you want to try to make sure both are being appropriately addressed. The more other issues that a person with MS has, the harder things can be in general. And so it's always better to just, have MS and not those other things rather than having, a bunch of other things too. Steroids are, useful to treat a lot of things. They're kind of potent anti-inflammatory agents. And so the fact that somebody gets some improvement with steroids doesn't necessarily mean that it's because their MS is being inflamed.
We had another question come in from Canada, and her question is about brain lesions, particularly in the memory centers. She's 51 and has some short-term memory concerns. Is it likely that neuroplasticity will help at her age?
Yeah, potentially. I was just thinking, because we also have another question that was submitted, question number 14 about brain lesions. I was trying to see if there's a way I can combine this, but so yeah, I mean, MS is, causes damage to the brain and spine. When it causes damage to the brain, sometimes it can lead to cognitive symptoms. It's very common, actually, things like memory impairment, difficulty processing, word recall, that kind of thing. Those things are all very, very common in people with MS. And presumably there's, more areas of brain that are damaged, the more likely you're going to have, that kind of thing. The questioner asked about neuroplasticity, which is kind of like, rewiring of the brain. And that may happen to some degree. It probably happens a lot more in people who are young, like kids, than it does in grown-ups. And there's not really an easy way to measure that. But the good thing about human brains, is that we have a lot of cushion. So, we like to talk about this concept of neurological reserve. And so with MS especially, but not, necessarily limited to MS, I might have a different reserve than you, Helen. And so the same amount of damage to my brain might affect me more than it would affect you if you have kind of a greater, a natural resilience to the damage. And so also not so easily measured, kind of how much baseline, resilience. We have, thought that probably relates to just kind of overall volume of tissue, overall brain volume. And it may to a certain extent, although I think, kind of recent studies have kind of made it seem like maybe that's not the best measure for, that we should be looking at necessarily. But there's something in there that, that distinguishes, that helps to kind of say why some people have it worse than others, beyond just like how many lesions they have and where those lesions are. I think there are some kind of innate factors to, like, that how much reserve a person has.
I will just give a quick plug. Our next issue of Informs magazine will be all about cognition. We have a great interview with a neuropsychologist in there. So if you are not already on our email list, please be sure to sign up, or you can go to mscenter.org probably next week to check it out. And then one more thing to announce as well. We have just put together a webinar on July 1st with Dr. John Corboy, discussing the results of the DISCO-MS extension trial data. So the trial that he did that looked at discontinuing drugs after a certain age. They have extension data, and that's going to be talked about on July 1st. So we will also be sending an email out about that.
Shall I start with the list? Okay, so we have a question here about bladder issues with MS. Like cognition, also very common for people to have bladder trouble. So, the bladder is part of the urinary system, but it receives input. Well, it sends messages to your, through your spine to your brain, telling you, like, I'm full, time to empty me. And then also, your brain is sending signals, down. So your bladder is at least partially under voluntary control. You have the bladder wall has muscles called the detrusor muscles that kind of fire and give you that sense of, gotta go time. And then you've got like a urinary sphincter, the thing that kind of opens up that allows the kind of outflow to happen. And so you can have in MS, either one of those areas be kind of a problem. So if you have kind of the urge to go, like if you gotta go kind of thing, you're peeing frequently, either daytime, nighttime, what have you, or you're losing urine. Sometimes that can just be because of detrusor overactivity, a so-called overactive bladder, which is, not unique to MS. There are other things that can cause overactive bladder too, but like, drinking too much coffee, for instance. But it's a very common thing in MS. And then on the other side, you can also have a kind of inability to relax that sphincter, that outflow tract. And that can lead to things like you get to the toilet and then can't go, kind of thing. Or, you go somewhat and then you kind of have to come back a little bit, like 5 seconds later, kind of thing. And so that kind of, those issues like hesitancy and retaining the urine, that's kind of on the other, that's the other path. And people can have one or other or potentially both issues. And there's a variety of different interventions that a person can do, either by, with their neurologist or with the neurologist and maybe some combination of neurology and urology as well. So that includes medications for overactive bladder. There's also kind of neuromodulation, things that kind of stimulate different nerves to try to get the bladder to act better. They do a thing called percutaneous tibial, no, not percutaneous. Percutaneous. I have to look it up. You're basically stimulating a nerve in the leg. Yeah, percutaneous tibial nerve stimulation, exactly, right. So that's one way of kind of helping to modulate the signals that are going to the bladder. Another one is there's a device called an interstim that actually gets implanted into a person's body that can potentially do that. Other things, and now you're talking about like kind of more advanced things that, things that would likely be run through like a urologist, but things like Botox, we do Botox for spasticity, muscles. You can also get Botox injections into the bladder for like bladder spasm, kind of relaxes the muscle there too. And then some people will need to do to have a urinary catheter, either intermittently or kind of a permanent one to help kind of drain the bladder. So there's kind of a lot of different potential avenues that a person can go down who's having bladder trouble, and often it can be useful, and that's one of the things that I think we don't think about enough. We don't ask enough necessarily, and sometimes people are kind of hesitant to bring it up with their doctors, but you shouldn't be because it is very common. Question 2. Have you heard of an MS cough? Nope, can't say I've heard of that. Has anybody else heard of that? MS cough. Is that your question? Okay. Usually I wouldn't put MS high up there as the thing that's causing that. I mean, so yeah, other things certainly can cause coughs, asthma, other respiratory issues, even gastrointestinal things like acid reflux can cause a chronic cough. So definitely bring it up with the primary, maybe see pulmonologist or gastroenterologist. Progression of late onset MS, question mark. Diagnosed at age 54, first sign was numbness in the left hand at 48. Okay, so late onset MS. So a few things we know about late onset MS. One, so MS, we're usually thinking we're diagnosing it like in younger people, between 20s and 40s. And that is, I guess, broadly speaking true, although there's actually quite a wide range. And I think in recent years, we've probably been diagnosing it older. And also younger kids can get it too, rarely can be diagnosed with MS. And one of the trends that we've noted is that time to reaching certain disability milestones tends to be faster with older diagnosis. And then with kind of regular adult diagnosis tends to be kind of medium. And then with kids, it tends to be the longest to reach these kind of disability milestones. Also, primary progressive MS tends to be more common in old people who are diagnosed older versus people who are diagnosed normal 20 to 40 kind of thing, and the least in kids. And so whatever, that kind of degenerative part of the MS seems to be more common kind of as people are older. there's always a question of when somebody's diagnosed at a certain time, whether that's actually when the disease started, right? In this case, that's clearly not the case. They have symptoms even, well, they have age 48. And so most of the time I wouldn't call 48 late onset per se. But even then, it's really not easy to know when the actual kind of biology started. And the more we know, the more we suspect that a lot of people, it was kind of brewing for a long time before it kind of erupted, so to speak. Yeah. Another question.
I find a lot of resource information about foot drop, but I don't have a problem with foot drop. I have the opposite problem. I tend to drag my heels, prematurely wearing out my socks, wearing out my shoes. And I was wondering if there was any kind of information out there to help with that.
Can you show me what you mean? I mean, I have a sense what you mean, but. Thank you for volunteering.
No problem.
Yeah. But when we drag our heels, it's often because we're not getting good lift with the front of the foot. And so that is kind of what we're talking about.
When I'm hearing foot drop, I'm generally envisioning people with their toes dragging across the floor and they're tripping over their toes.
That can happen. Yeah, but depending on how good you're lifting like that, you might not get that. But yeah, if it's hard to kind of walk on, I don't know if you can walk on your heels for me. Yeah. That's actually not too bad. Yeah. So thank you for your volunteering. So yeah, I mean, you try to do an evaluation. Hopefully you work with your doctor and perhaps also a physical therapist or physiatrist, and they can kind of pinpoint what's actually, weak and try to target interventions, often be like physical therapy kind of thing. There are now, of course, like electrical devices that can provide stimulation to muscles and nerves in the leg in people who have MS who are weak. So there's the walking by MS, there's the psionic neural sleeve. Those things can potentially be helpful. Sometimes just having better footwear can be useful. And of course, there's the AFOs can help people who have foot drop and to keep from kind of scuffing the front of their foot. It kind of maintains that. That might not necessarily be ideal for you, but there might be some other kind of modification that can be done that can improve that. Yes.
Isn't there a stimulator that attaches to the calf of the leg, which helps you to pick your?
I think you're thinking about the walk aid, the walk aid by MS. Yes, there is something like that. Mm-hmm. Mm-hmm. Yeah, and we have physical therapists at the university who demo these devices with people and see if it's useful or not. Yeah. Moving on. Is being diagnosed with secondary progressive MS at 62 rare? No, not particularly. That's kind of right in the range when we see that. So just to remind folks, secondary progressive, so we kind of distinguish between different subtypes of MS. Relapsing remitting is what most people get diagnosed with when they first come to medical attention. And then after some period of time, some people who have relapsing remitting MS will transition to secondary progressive MS, in which relapses become fewer or non-existent, and instead there can just be kind of a steady accumulation of disability. Versus the primary progressive MS, which is that steady accumulation of disability from the beginning. But yeah, 62 is kind of the right age for that. Next question. Will your immune system be compromised much more during your second year on Mavenclad? Took 9 months for my lymphocytes to rebound after year 1 on this DMT. Okay, I think I'll preface this with I don't prescribe a whole lot of Mavenclad. It's a medication that depletes immune cells, lymphocytes, and they can stay depleted for a long time. And I don't have any reason to think that it wouldn't be similar on the second go around. Now, you don't have to necessarily get another round of it. So it's typically given in kind of cycles, month apart in year 1 and then again in year 2. But if there's some issue, and especially if this person is like experiencing complications, infections, and so forth, then it might be worth a discussion whether it's even worth doing the next round of that medication. So I don't necessarily know enough to, but like Kelsey said at the beginning, talk to your neurologist. Next question: has immunotherapy been tested for MS? If so, what are the results? Yep. All of the disease-modifying therapies we use are immunotherapies. I wonder what they meant by that. It would be good to have other types of drugs that are not immunotherapies, especially things that are like somehow protective of the nervous system, or remyelinating, regenerative kind of things that don't, operate strictly on this kind of, okay, let's shut the immune system down kind of principle, because those are the areas that are kind of missing right now in MS. Yes, sir.
So piggybacking on that a little bit, what are your thoughts? I know some of the preliminary studies on BTK inhibitors have not been favorable. What do you think the future holds for that?
Oh, so the question was about BTK inhibitors, which is a new class, new to MS class of medications that are currently in clinical trials. There's a bunch of different drug manufacturers that are making their versions, and we're studying them in different subtypes of MS, relapsing, remitting, progressive, et cetera. And some of the earliest studies have started showing results, and what we've seen is that, for one, in relapsing remitting MS, they're kind of, they're okay. They're not really as powerful as we thought they were going to be, which I think some people were a little bit surprised or let down by that. But then also interestingly, one of the studies looked at secondary progressive MS, and at least compared to the placebo group, there did seem to be some slowing in the people who received the BTK inhibitor, some slowing of the progression, which is always nice to have because we don't have as many drugs for progressive MS, and we have very few clinical trials that have demonstrated success. And so even though the success was fairly modest, and even though it was against a placebo, not like an actual MS medication, it was still interesting, and I think it'll likely join our kind of MS armamentarium. Now there were some issues with liver in this class of medication, so that's going to have to be something that we'll need to monitor closely in people who go on this thing. But I think it may be a useful treatment for some who have progressive MS potentially, especially if they're not kind of responding to our traditional, our existing treatments, I should say. And that kind of split is not one that we've really seen yet. The other medication, well, especially like ocrelizumab, that was studied in both progressive and relapsing MS and had positive trials in both. It was clearly very effective at shutting down the immune, the inflammation in relapsing MS, and then modestly effective at slowing down progression. So we've not seen this where it's like doesn't really have a huge impact on the overt inflammation, but it is working on the whatever underlying degenerative process is going on in the smoldering, what have you. Yeah, so what is the mechanism there? I think is really interesting question. And could you potentially use something like that in conjunction with, say, an anti-B cell therapy, something like that? You know, would be an interesting study too.
And I will share the presentation that Dr. Alvarez did at our Spring Education Summit. His research updates have focused heavily on the BTK inhibitor trial results. So again, that's on our YouTube. It's our Spring Education Summit.
Yes. So mechanistically, we know that they do operate not only on like the adaptive immune system, meaning like B cells, but also on certain resident what we call glial cells in the brain, like microglia, which we think have an important role in MS. And so possibly there is why it's making a difference. Number 7, next question. What is life expectancy for relapsing remitting MS? Someone is currently treated with Ocrevus, has had no lesions for the last 5 years. Initial exacerbation that led to the diagnosis was severe. So I guess they were wanting me to know what their life expectancy is. Well, my crystal ball says there has been some research. There's a kind of a very quoted study that looked at like life expectancy in people with MS versus people who don't have MS. And the number that gets cited is 7 years on average less. I think I would put some major kind of asterisks next to that. I think, first of all, it wasn't that long ago that this study came out, but I think a lot of the people that were studied, a lot of the patients that were studied, was kind of in the current era where we have all our good treatments that we have. And so I suspect that wouldn't be the case. Now, most of the time, people don't die of MS. They die with MS. With, I think, some exceptions where somebody is like very, very affected, especially at a young age, and then perhaps they could succumb to some complication of MS. And so that could potentially, drag down the overall average. But I think by and large, most people who are kind of not otherwise sick in other ways and whose MS is being kind of appropriately attended to, I suspect they have normal life expectancies. So yeah, so I wouldn't worry too much about that, but definitely don't smoke and make sure your blood pressure is under control, cholesterol, your normal cancer screenings and all that stuff.
This is a very controversial subject, but have there been studies, and what are the results on the studies as far as the medical marijuana and MS?
I don't think that's that controversial. Maybe it's controversial here in Wyoming. Yeah, maybe here in Wyoming. Yeah, yeah, Colorado. But in reality, we don't have a lot of the highest quality evidence on medical marijuana, and that's probably due to the kind of legacy of the way it's been scheduled on the federal level and how, as a research institute, we get a lot of kind of federal funding, and so it's very hard to study in the way that we would like to, a randomized clinical trial kind of thing with medical marijuana. Now, that said, a lot of my patients have used it. And they tell me about it, and we've done surveys and so forth. And symptom-wise, it can potentially be very helpful, especially with certain things: pain, spasticity, anxiety, trouble sleeping, things like that. And there's different sorts, and I'm not necessarily an expert on this, but there's also, there's different ways you can get it. Gummies and edibles are very popular, and there's different components of it too. So like the THC is the kind of psychoactive component, the one that gets you high, the one that makes you feel kind of like that. But there's other parts, especially like CBD, that can potentially be useful, but without having as much of that kind of thing. And so if you wanted to stay more clear-headed, but you wanted maybe some of those beneficial effects, you might want to go down that other path. And maybe you can look into different ways of getting it into your system, topical as opposed to like, smoked, for instance. And so yeah, it's an area that I would like to see more actual study on, and not just to see, is it effective? But again, like we talked about before, how safe is it? I mean, of course, marijuana for a long time, and so I think it's probably safer than tobacco. I'll put it that way. Yes,
I'm coming from a law enforcement
please.
background.
Yes, I'm eager to hear this.
There was a study that was done that showed that smoking marijuana is actually worse for your lungs than tobacco smoke.
Interesting.
And so, and we were even shown photos of this is
Yeah.
lungs on marijuana smoke
Yeah,
versus tobacco smoke.
that's interesting.
And the marijuana lungs were just jet black
Yeah.
and just covered in stuff.
Yeah.
And the
Well,
tobacco smoke didn't look as bad, but this is also 1990, so.
I mean, tobacco is really bad for you in pretty much all respects. Comparing the two, I don't know, but like, it's probably not a good idea to be smoking anything, to be perfectly honest, because you need your lungs to breathe and stuff. There's been many studies that have looked at the kind of harmful nature of tobacco with respect to MS specifically, and I haven't seen anything that has looked anything nearly like that as far as marijuana goes. But you can easily imagine how somebody's having issues with cognitive impairment, stuff like that. It could potentially be worsened if you're using heavily, that kind of thing. So I would definitely exercise caution in that way if you're going to be operating a vehicle or something like that. All of those things. Don't be like Dr. Gross said I should go out and smoke all the marijuana I can. No. But potentially as an adjunctive kind of treatment to help alleviate certain MS symptoms, I think it could potentially be useful. Yeah. Yes. Helen.
I did warn you. I know of studies that have been done or are being done, or I've heard of them, let's say
Mhm.
that, on relapsing MS and brain cell, or not, stem cell.
Yes.
Can you tell me a little bit about that? Maybe, but also, is there any study that then goes up to progressive?
Thank you for your question, Helen. So stem cells is kind of I don't know if I call it a hot topic, but it's definitely just a warm topic. And it's been that way for a while now in MS. Where I think people get this, hope or feeling about it is that, it's that maybe this can be the thing that kind of repairs the damage that has been done by the MS. Unfortunately, most of the stem cells that have been studied to date in MS have been what are called hematopoietic stem cells, which are kind of bone marrow derived cells that will become your immune system. So when people have gotten this type of treatment, and I actually think there's a question here about somebody who did have a stem cell treatment, and then they said it did little to nothing. So it's not a panacea. No, I mean, many people have gotten it, and you haven't seen people like jumping up out of the wheelchairs and running races kind of thing. So the idea with the hematopoietic stem cell transplantation is you're kind of rebooting your immune system. And so still, generally speaking, operating on the kind of same principle as what we're doing with our immunotherapies, right? You're kind of altering the immune environment to prevent it from continuing to attack the brain and spinal cord. But you're not actually treating the brain and spinal cord per se, with these treatments. And so that's where I think there's a little bit of a disconnect. between what, that the kind of hope with that and what we're actually seeing. So it's not an approved treatment for MS, it's still an experimental, and we have an ongoing clinical trial, Beat MS, at the university where we're enrolling people to see whether it is actually beneficial and worthwhile. We know it can potentially come with harmful side effects, including the risk of death. And a lot of that risk is kind of right up front when you first have what's called the conditioning regimen, and they kind of have to wipe out, or at least partially wipe out, your person's immune system before they do it, implant the stem cells. And so there's a significant risk associated with it, and then the benefits again are kind of uncertain. We think that there may be some people with particularly aggressive forms, like I guess relapsing remitting, but like where it's very inflammatory and they're just getting worse and worse and worse, and especially not responding to what we currently have available. Those people might be good candidates for this approach, but I mean, we'll see with study. But again, going back to this idea that we need other types of treatments, remyelinating repair treatments, that I don't know that stem cells is going to be that thing. Okay. Oh, I think this might have been your question. We have another question about the maximum age of a drug like Ocrevus. So we kind of addressed that. We got the stem
Dr.
cell
Gross,
question.
we did
Yes?
have a follow-up question on that.
Mhm.
Someone was asking if there are guidelines for kind of, or things to think about how you would know it's the right decision to go off of your drug.
No real formal guidelines yet, but I think we're getting to that point. I think the problem with that is that sometimes that can get kind of misinterpreted, like used by things like insurance companies to be like, oh, nope, you're 55, we're done paying for that, kind of thing. Yeah, again, I don't practice that way. I think you have to take the whole person and all the different factors into account when you're trying to determine whether discontinuation is a reasonable option. And we've been talking about it as kind of this all or none thing. You're either on drug or off drug, but there's other avenues also, including what we call de-escalation, meaning like say you're on Ocrevus and you're getting it once every 6 months. Well, why couldn't you get it less frequently than that? Why couldn't you get it once every 9 months or once a year? That way, we actually have pretty good data to suggest that the beneficial effects are lasting longer than 6 months, whereas not getting it as often and not having as high a kind of a cumulative dose, you may be lessening some of the long-term concerns as far as the immunity and safety. So de-escalation is a related concept that we're really looking more into now, and whether some people, especially people who've been who are a little older and who've been kind of stable or whatever on treatment for a long period of time, whether they can kind of space things out or go to maybe a less potent immunotherapy. Yes.
So along the lines of de-escalation, what can you elaborate on relative to maybe reducing the dose of Ocrevus, where it might be a lesser dose that you would receive based on body weight or other factors like that? Is there?
Body weight is an interesting idea. I can share my anecdotal experience first, which is that I've been talking to folks about this for the past couple years now, and we've had a lot of people move to doing less frequent infusions. And by and large, I think the vast majority of people seem to be doing equally well, if not better, because a lot of the times they were struggling with kind of recurrent sinus stuff or other issues, and now that their immune system is getting a little bit more chance to recover in between infusions, they're actually feeling better. And so yeah, I would say it's been a positive overall. And we've actually got, since really the beginning of the COVID-19 pandemic, we've had a lot of experience, because you may recall back then, there was a lot of like, oh God, we didn't know whether we were going to be killing people with these drugs or not. So a lot of people there was a hiatus and so, and then, we've subsequently looked at what happened to, people who've had, gaps in there between infusions, and not just us, but around the world. And by and large, it was fine. I mean, it didn't adversely affect their MS to go a year in between infusion or longer in some cases. Yes.
So as a follow-up, I actually, question, but it kind of dovetails into this a little bit. So can you explain, Ocrevus is a B-cell depleting therapy. It's my understanding that it works by targeting CD20 presenting B cells and basically eliminates those, but your body retains the young B cells as well as the plasma cells, leaves those untouched. Do you know anything about the life expectancy of a plasma cell? How long will it stay around? Could that keep someone healthy? And if you're continuing to kill the, B cells that are in the intermediate range, is there any chance that any of those younger ones can actually mature to become plasma cells and help to retain some immunity?
Okay, interesting the way you phrase it, because I mean, yes, it does spare the long-lived kind of plasma cells. But in a lot of time we think about it, we're thinking about like, not how do we retain immunity or build immunity, but how do we prevent autoimmunity?
Yeah, I guess though, it goes back to it's the CD20 presenting cells that are the ones that are actually inflicting that harm, whereas maybe the plasma cells aren't as much.
Yeah,
and
I mean, that's
also
probably
at the
true.
same time helping to retain immunity.
Yeah.
Preventing you from getting illness.
Yeah. So I think, yes, to answer your question, yes. And you retain a lot of antibodies, just kind of free floating antibodies that, that you're developed over the course of your lifetime that help you be immune to lots of different things. I'm not sick.
Plasma cells would actually be the ones that would be helping to maintain those antibodies.
Yeah, in part, yes.
So you'd want to keep those around if you want to maintain that.
Yeah, for sure. Take a little bit of another route on this question too, is that, part of why we think it's okay for people to extend the interval between their infusions is because when those B cells do grow back, they're not necessarily the brain-hating ones that grow back at first. They're like, the naive, immature, whatever. They don't realize that you have MS yet. And so then,
Inductive.
What's that?
Inductive therapy changes.
Sure.
Immune system.
Sure. Yeah. In a way.
It doesn't come back.
Sure, but eventually, especially in younger people, if you were to do nothing, then they might be at risk for, the disease coming back, after 18 months, say. But yeah, so it's, the reason is that, we check people's B cells and when they're repopulating. And a lot of people will start to grow back their B cells at around the 6-month mark, which is again why, Ocrevus has been dosed in that way. But even if you're starting to see some B cell reconstitution, it doesn't necessarily mean that the person is at risk for the disease flare-up. And it's probably because those early CD20 presenting B cells are not the damaging ones. Yeah. Good questions.
Since we're talking about Ocrevus, et cetera, they're all B cell therapies. So why is Ocrevus every 6 months, but like Kesimpta is every, like it's 28 days or once a month?
Yeah.
Like, is Ocrevus so much stronger
It has to
versus
do with
Kesimpta?
the dose and the route of administration and the pharmacokinetics of it. So you're just, it's going to last longer in your system, the IV, all of the IV versions versus Kesimpta, which is a lower dose and delivered subcutaneously. And it just has to do with those principles that, yeah, they're working in the same path. They're eliminating your B cells. They just, one lasts a little bit longer than the other. Yeah. Oh, moving on. How about this one? Are there treatment options becoming available, or how far are researchers from finding a cure? The cure word. I'd like to say they're close, but I mean, we'll see. You know, this is an area that this is part of the reason why I'm into this field is that you know, there's a lot of changes and we're seeing, you know, new developments, new drugs all the time. You know, we've talked already a bit about like, you know, remyelinating type therapies, and I think, you know, hopefully we'll see one of them be successful in clinical trials, and then we can start to roll that out. But you know, if you think of cure, and I think people have their own ideas about what that really means. I mean, in a lot of cases now, we diagnose people, you know, especially early on. We start them on treatment, especially like a highly efficacious treatment like the ones we've been talking about, and they do great. You know, they don't go on to have progression or, you know, end up, you know, being disabled down the line, and they just kind of live their lives, their, you know, jobs, their kids, and all that stuff. And so, is that a cure? I mean, I think most people don't really consider that to be a cure per se. You know, I think there's also this idea that a cure means it's kind of a one and done situation. You know, it's kind of a surgical, like, you know, you remove the bad thing and then it's done. You don't have to think about it anymore. You're no longer a person who has that thing. Unfortunately, we can't really do that with MS. And so, you know, even in, you know, situations like where people have had hematopoietic stem cell transplantation, where their immune system has been rebooted, some people actually have needed to then go back on immunotherapies because actually, you know, the reboot didn't take, or it took for some time, but then you know, the body remembered. And so, yeah, so, I mean, I wouldn't necessarily call that a cure either. There's, you know, talking about kind of why people get MS, and we didn't go into this before, but, you know, we think that the trigger for people's immune systems ultimately kind of turning on them is maybe the Epstein-Barr virus, the virus that is associated with mononucleosis and other conditions. Turns out that almost everybody with MS has been exposed to the Epstein-Barr virus. And probably what is happening is that their body, their immune cells are not digesting it, or they're not dealing with it in a kind of a normal way. And so that ends up creating this bad kind of situation where the immune cells eventually turn on your own tissues. And so, interesting, right? But, you know, at this point, there was not really anything that we can do about it, but maybe at some point we will have an effective vaccine against this virus. And then at that point, maybe there will be no more MS. Right? That'd be great. So that could potentially be a cure, right? I know that there are companies that are working on developing vaccines against Epstein-Barr virus. And so, you know, potentially we could eliminate it that way. You know? So there's more than one way to kind of practice, but yeah, it does depend a little bit on a person's definition of cure, but we need more research in all of these areas for sure. Okay. Talked about stem cells. Oh, here's a question. Does a PEMF mat, and then I have the website here, help people with MS diagnosis? Woman said her mat helped her feel better. She had less fatigue. Have you heard of this mat? And is there any research on it? I have not heard of that mat. I did go to that website though, and I looked at it, and it looks like it's using some kind of infrared beams or something. Kind of pricey. I will say it's kind of pricey. So no, I did not see any research that suggested that it was beneficial. Usually if it's something like that had research, it would be like right there prominently on the website, like was shown in this trial to like help people with MS. They had like some anecdotal kind of like testimonials. It's like, you know, this helped me. And so, you know, my general rule of thumb on that kind of stuff is like, you know, you spend your money how you want to spend your money, right? It's hard for me as a doctor to make recommendations on the basis of just like, you know, Bob said that it really helped him, you know, kind of thing. I mean, I make a mental note of that. But like whether that's maybe really just applicable to Bob or more broadly applicable, really, you know, we need better data, more data especially, stuff like randomized clinical trials, which is our gold standard in medicine. That tells us that, for one thing, it does actually work in a broad group of people. And then it's not just a placebo effect. Nothing wrong with the placebo effect. I mean, it is an effect, right? It does do something to people. It's just, do you want to spend $1,200 for your placebo, or, maybe you do, So not something that I can recommend yet, but if you do try it, let me know how it goes. All right. Okay, here's another question. Can lesions in the brain only lead to cognitive issues, or can this lead to mobility issues of different sorts? I don't have issues with mobility. MRIs of the spine were clear of lesions, but I've had balance issues, stuff with like dropping things, lack of dexterity. And then they're wondering if it's, and are they imagining this? Is it all in their head kind of thing? They didn't say that it is all in their head, but, obviously what people think. And I say, yes, it is in your head, but, so MS is in your head too. So for sure, brain lesions can cause cognitive symptoms and can cause issues with balance, mobility. Yeah, I mean, we think of spine lesions as being the kind of primary drivers of weakness and trouble walking and stuff, but brain lesions can also have an impact on that for sure. And then the other part of the question was, do people who have only brain lesions commonly progress to have lesions on the spine, or is there a chance they could stay in the brain only? Well, I mean, I think if you're, being treated for your MS, hopefully you don't get new lesions anywhere, brain or spine. I mean, that's the goal of treatment, really, is to prevent further damage to your nervous system. And so, yeah, I mean, I think there's a good chance that you could not have lesions on your spinal cord. Yeah. Is that all the questions here for that were submitted for today? Then we have some questions from the Q&A that we did before that we didn't get to all the questions for. So I'll start with that. But if anybody has any additional ones, just interrupt. Okay, so this question is about Kesimpta. They're wondering if some of the daily symptoms, like balance, fatigue, dizziness, brain fog, will they improve with treatment, or is it really just to prevent the disease from getting worse? So this is a great question. So, I mean, yeah, traditionally, that's what we've said about all of these disease-modifying therapies, is that they're preventative. They're designed to prevent further damage to the nervous system, and therefore, then they shouldn't really be having an impact on your day-to-day symptoms, which are presumably due to the damage that's already been done. Because as we've said several times, we don't have anything yet that really repairs that damage in your brain and spine. That said, we have seen, especially when people get started very early in the process, and especially with some of these more high efficacy therapies, is that a lot of the symptoms do seem to improve from, that when we first see the person to, say a year, 6 months or a year later, kind of thing. And some of that is just kind of natural healing that's going to happen, kind of a regression to the mean kind of thing. We know that MS people can have this kind of thing, and if when you first come to medical attention, you're usually down here, you're likely going to kind of come back up at a certain point, just kind of the natural course of the illness. But I think it's more than that. I think these medicines, again, especially kind of more highly efficacious ones, we're probably allowing the body a little bit more of a chance to kind of repair itself, so to speak, than by just doing nothing. And so yeah, it does muddy the water a little bit in terms of that, but I think in a good way. And so I don't guarantee that people will get better, because again, that's often we don't see that. But it is possible that some of that stuff could improve over the next several months. Yeah. And if not, maybe there are other things that can be tried apart from the Kesimpta, other, what we call symptomatic treatments for the fatigue or the brain fog or whatnot, that might be beneficial. How do you time vaccinations with Kesimpta? Okay, great question. And vaccinations, very important. I haven't been getting as many questions. Actually, in the past few weeks, we've been getting more questions, but for a while there was a little on vaccination questions, but very important. It's part of, I think, good, preventative care. And what we know about Kesimpta and really probably all of our B-cell depleting therapies anyway is that they probably impair a person's response to vaccinations. They're still maybe a good idea to get. And with the IV stuff, the Ocrevus, the Breyanzi, rituximab, we usually tell folks, wait a while from their last infusion. So, really the farther you are from that last infusion, the more robust your response is likely to be. But you also kind of have to weigh that against when is flu season, and when are you going to be going on that trip to see the grandkids and so trying to time it in that sense also matters too. And you're probably getting some response, even if, and we can't really easily measure. I mean, we can measure antibody titers, but that doesn't represent all of a person's response to vaccination. There are other cells involved, T cells, et cetera, that we can't really measure that well. And so you have to weigh those things. And with Kesimpta, I mean, as the person says, you're kind of getting it every month, and you're never really that far from the last injection. And so whenever, just get it whenever. It probably doesn't matter. What muscle relaxers do you use for MS spasticity? Dosage, frequency, do you stay on them for life? A lot of different muscle relaxers for MS spasticity. I think I had a talk on this maybe a couple of years ago. They can be very useful dealing with people who have muscle spasms, cramping, pain, that kind of thing. They go by a variety of different names. Baclofen is a common one, tizanidine, cyclobenzaprine, methocarbamol. So we use a lot of different ones in different doses, and it really just depends on kind of how bad your spasticity is, how well you're tolerating them. Some of these can have a lot of them actually have a tendency to make people feel fatigued, like tired, sleepy. So I'm trying to balance that out with whatever benefit a person is getting. I saw that from the treatment is a thing that we do. And then of course there's other treatments for spasticity. That depending on how that person has it, there's Botox injections that can be done. There's baclofen pumps which deliver the medicine directly into the spinal canal. It can be more effective and potentially less problematic from a kind of side effect standpoint too, but it requires a surgery to do, and it needs to be refilled periodically and adjusted. And you stay on them for life. I mean, you don't have to, but they're working. A lot of people do. I mean, the MS is kind of for life. Yeah, that's not usually one that we talk about in terms of discontinuation with older age kind of thing. Because if it's helping you day to day, then you're tolerating it, then probably want to stay with it. 2 minutes. We have time for one or two more. Any more from the crowd? Okay. How to understand if you're having a flare-up or something not related to MS? Does everyone with MS have flare-ups or just specific types of MS? Oh, yeah, that's going to be a long one. So it can be difficult to know. I'd say, we have, as neurologists, have kind of long been in this business of trying to distinguish what we call relapses from pseudo-relapses, the former being driven by some kind of new inflammatory activity in the brain or spine, and the latter being presumably related to existing damage that a person has that has not necessarily gotten worse, but it's just the signal was getting through, and then suddenly it's kind of not getting through as well. And so, we try to distinguish that because, with a relapse driven by new inflammation, that suggests that you're not on good treatment and we need to change something. Versus the one that's, just that the scar and the signal not getting through quite as well. And that's more like, there's not really a better treatment that would have prevented that from happening. And so sometimes MRIs can be useful in distinguishing those two things. If you're a person with MS who's on highly effective therapy and the symptom is kind of very similar, it was your left leg that first started your MS journey, and now it's again your left leg, and you've noticed it these past few days, and maybe it's in the context of not getting enough sleep or being sick or something like that. That's a pretty classic story for what we call pseudo relapse. And the goal there is to try to support the person through that symptom. If they're sick, do they need an antibiotic? Do they just need more sleep, more rest? Sometimes it's being driven by excessive stress. Whatever trigger you can kind of identify, you try to remove that from the equation, and then you just hope with time that things will kind of get back to where they are, and it typically does. So that's how we do it in a nutshell. But talk to your doctor. Obviously, you send us a message, or you come in for an urgent visit, and we can kind of go over what the difference is and whether it's worth doing additional testing like MRIs or other types of tests. And I think that might be it for time. Thank you guys all for your wonderful questions. This is a great group discussion. And yeah.